Welcome to this lecture on vitamin D. In this lecture, we'll examine vitamin D biosynthesis and clinical implications for evaluation and treatment. You can find the notes as well as objectives for this lecture in the course module. Vitamin D serves as a cofactor in several biochemical reactions, including those associated with monoaminergic synthesis. Vitamin D is suspected to be associated with homeostatic, trophic, and immunomodulatory effects. Vitamin D receptors, VDRs, are found in nearly every tissue. Vitamin D3 is derived from animal sources. Provitamin D3 is converted into previtamin D3 under the influence of UV light and then into cholecalciferol under the influence of thermal isomerization. Vitamin D2 is derived from plant sources. Provitamin D2 is converted into previtamin D2 under the influence of UV light and then into ergocalciferol under the influence of thermal isomerization. Both vitamin D2 and D3 are then processed by several enzymes in the liver into 25-OHD3, calcidiol. The most critical enzyme in this step is 25-hydroxylase. Calcidiol is then processed by renal enzymes, namely 1-alpha-hydroxylase, into 1-alpha-25-dihydroxyvitamin D3, or calcitriol, which is the active form of vitamin D. Calcitriol promotes increased calcium and phosphorus absorption in the intestines. Calcitriol also promotes activation and mobilization of calcium stores. Increased calcium triggers a feedback loop that stops the activation of vitamin D. Parathyroid hormone stimulates the activation of vitamin D by the kidneys, which is under the control of calcium. Decreased calcium levels stimulates parathyroid hormone, where increased calcium levels inhibit it. Because vitamin D has such wide implications for several processes, including monoaminergic synthesis, it is recommended to check and treat vitamin D insufficiency and deficiency in most cases where there are neuropsychiatric symptoms. This is especially true with depression. In a review of 61 articles, a clear inverse relationship was found between vitamin D levels and clinical depression. Although across-the-board treatment is not currently recommended, treatment of deficiency is certainly recommended. What follows is a comprehensive evaluation and treatment approach to vitamin D, with consideration for calcium, given that these two are so closely related. Although the conventional cutoff for a 25-OHD3 is 30, in the context of neuropsychiatric symptoms, the cutoff should be increased to 60. A vitamin D level should always be checked alongside a calcium level to fully illuminate the impact on calcium levels and rule out any contributing conditions. Vitamin D is decreased in osteomalacia, rickets, osteoporosis, autoimmune conditions, celiac and non-celiac gluten sensitivity, Crohn's disease, chronic kidney disease, asthma, cardiovascular disease, hypertension, mood disorders, schizophrenia, fibromyalgia, and cancer. Vitamin D is increased in the context of hypercalcemia and vitamin D toxicity from excessive supplementation, discussed later. If the vitamin D level is less than 60, then consider vitamin D 1,000 to 2,000 international units once daily with the addition of K2, as this helps direct the activity of vitamin D. If the vitamin D level is less than 30, insufficiency, then consider vitamin D 5,000 international units with K2 once daily. If the vitamin D level is less than 20, deficiency, then consider vitamin D 50,000 international units once weekly for 12 weeks. In some cases of insufficiency, I've repleted with 50,000 international units once weekly for 4 weeks to expedite recovery. Regardless, the 25-OHD level should be repeated in 3 months, or sooner if using high-dose vitamin D for a brief period of time. If the vitamin D level is repeatedly low, then it's recommended to evaluate the gut using a comprehensive stool analysis and consider food allergy and sensitivity testing. Celiac disease and non-celiac gluten sensitivity should be ruled out. A calcium level should be checked alongside a 25-OHD to rule out factors contributing to vitamin D abnormalities. If the calcium level is greater than 10, hypercalcemia, then discontinue any thiazide diuretic and lithium medication-induced and TUMS, milk alkali syndrome, then repeat a calcium level. If this is not applicable, or if the repeat calcium level is still elevated above 10, then check a parathyroid hormone. If the parathyroid hormone is low and the 25-OHD is low or normal, then check SPEP or UPEP, serum-free light chain assay, and possibly consider a bone marrow biopsy through hem-onc referral to rule out multiple myeloma. If the parathyroid hormone is low and the 25-OHD is low, then consider high-resolution CT to rule out sarcoidosis. If the parathyroid hormone is low and the 25-OHD is high, and the BUN creatinine GFR is abnormal, and an ultrasound of the kidneys reveals bilateral renal atrophy, then consider appropriate treatment of chronic kidney disease and referral to nephrology. Treat the vitamin D, as the active vitamin D will be low, and consider cinacalcet to increase the sensitivity of calcium receptors on parathyroid chief cells. Checking a 1-alpha dihydroxy vitamin D3 here will inform the impaired conversion to active vitamin D. If the calcium level is less than 8 and the patient is status post-multiple transfusions, transfusion-induced, then replace and follow trend. The patient has recently undergone a gadolinium-based MRI or has hypoalbuminemia. Then monitor, as this is pseudo-hypoparathyroidism. Here, it helps to calculate a corrected calcium to highlight a true level. The patient is on a proton pump inhibitor, bisphosphonate, or cinacalcet, medication-induced. Then discontinue and check phosphorus. Replace the calcium, reduce phosphorus, and repeat 25-OHD, calcium, and phosphorus. The patient has a systemic illness such as infection, sepsis, burn, renal failure, rhabdomyolysis, tumor lysis syndrome, or pancreatitis, then treat the systemic illness and repeat labs. If the repeat is low, then check a parathyroid hormone and 25-OHD. If the 25-OHD is normal, but the parathyroid hormone is low, then consider hemochromatosis or Wilson's disease. If the 25-OHD is high, but the parathyroid hormone is low, then discontinue supplementation. If there is persistent hypocalcemia, then consider recombinant parathyroid hormone, an irreversible condition. Early onset of rickets and hypocalcemia may be indicative of a 1-alpha hydroxylase deficiency, an autosomal recessive disorder of this gene and associated enzyme. The drug of choice for hypocalcemia is calcium carbonate, 600 milligrams once to twice daily for 3 months, with ongoing monitoring of calcium levels. Thank you for listening to this presentation. You'll find references in the written notes. If you have any questions about the material, please contact me.